To be a former MRDA awardee a couple years back, which led to a KO 8 through NCI, which I'm currently in year 2 of. And I will definitely, as the K goes a little further, come back to this group to present that research. And this is a separate research project, which is about body image disturbance among head and neck cancer survivors, which is currently in year 1 of an R21 through NCI. So by way of reintroduction, I'm a head and neck cancer surgeon at MUSC and also a faculty member of the Department of Public Health Sciences and a member of the Cancer Control Program. So the outline of the talk today, this is really sort of a PowerPoint reworking of the AIMS page, which was intended to go in for an R01 in June to a funding announcement about cancer control clinical trials. So by all means, please feel free to interrupt along the way, but the sort of structure of this is to walk people through what would look like an AIMS page. So head and neck cancer, for those of you who have never encountered someone with head and neck cancer before, it occurs in the mouth, throat, jaw, and face, so areas that are important for cosmesis and function. And as a result of that, treatment of head and neck cancer results in highly visible and socially significant changes in parts of the body that are really integral to self-identity and interpersonal relationships. And so as a result of the combination of surgery, radiation, and cytotoxic chemotherapy, head and neck cancer survivors suffer from really significant morbidity related to disfigurement, impaired swallowing, and challenges speaking. And it's been known for a long time that this constellation of impairments results in a significant percentage of head and neck cancer patients expressing body image concerns. Having some level of concern about body image following head and neck cancer treatment is common. However, when these concerns become more significant, we then term the disorder body image disorder, and it's characterized by a displeasing self-perceived change in appearance and/or function. Head and neck cancer-related body image disturbance is associated with devastating psychosocial morbidity and decreased quality of life, with high rates of social isolation, stigmatization, depression, and ultimately a 2.5 higher rate of suicide compared to other cancer survivors. To date, effective strategies to manage body image disturbance among head and neck cancer survivors have been lacking. Multiple small randomized controlled trials have looked at interventions that really focus on the appearance concealment aspect of it. So there's been a skin camouflage program and a cosmetic rehabilitation program. Building off of an intervention that was helpful to manage body image among breast cancer survivors, which was an expressive writing and self-compassion exercise, when applied to head and neck cancer survivors, was also found to be not effective. So to date, there are really no clinically effective interventions to help these patients suffering from significant body image concerns. And so what our team has proposed is that instead of focusing on concealing the disfigurement, which is what most of the interventions to date have really focused on, we think that a more promising strategy is to actually target the underlying cognitive and behavioral challenges faced by head and neck cancer survivors. So there's some preliminary data. There's actually pretty strong data in the non-disfigured patient population world, so those with anorexia or body dysmorphic disorder, that time-limited CBT can be a helpful and effective intervention. Whether those same principles apply to patients who have externally visible and really significant disfigurement is unknown, but we think potentially it could be a promising strategy. So based on that premise, we developed BRIGHT, which is our intervention. It's a manualized CBT intervention targeting the cognitive, attitudinal, and behavioral components of head and neck cancer-related body image disturbance. In South Carolina and many parts of the country, head and neck cancer care is very regionalized. So patients will drive often 75, 100 miles for surgery and then go back to get radiation close to home. So getting people back and forth for mental health services is quite challenging. And so to overcome that potential obstacle, we decided to deliver the CBT intervention using a telemedicine platform. And so all the participants in the study get a locked study issued Wi-Fi enabled iPad that they can use for the telemedicine platform. The BRIGHT intervention itself consists of a therapist manual and a patient workbook. It's delivered in 5 weekly sessions. Each session is approximately 1 hour, and the content of the sessions is setting goals for treatment, introducing patients to the cognitive behavioral model, discussing cognitive restructuring, avoidance, safety behaviors, and social support, and then relapse prevention. So in our single-arm pilot study of BRIGHT, we demonstrated its feasibility in terms of delivering the high fidelity intervention with low rates of technical issues and low study dropout. We also showed that it was acceptable to both the participants and the psychologists in terms of its timing, method of delivery, number of sessions, content of sessions, and then likelihood of recommending Bright with almost, this is on a Likert scale of 0 to 5, so almost all participants were very highly likely to recommend Bright to someone else who'd been treated for head and neck cancer. Our single-arm pilot data from the 10 subject also showed that Bright had a strong preliminary efficacy signal, so at 1 month post-Bright, there was a mean 34% reduction in mean body image scale scores, which is a validated measure of body image disturbance among cancer survivors, and this effect persisted out to 3 months post-treatment. And qualitative semi-structured interviews with participants suggested that they perceived that the Bright program helped them improve body image coping strategies. And so here are a few illustrative quotes about how patients felt like they grew as part of the Bright program. So based on that single-arm pilot data, we applied for and were awarded in our 21 from NCI, looking at a pilot randomized controlled trial comparing Bright to dose and delivery matched active control. The active control condition is also 5 weeks. Patients get an iPad, but instead of meeting with a psychologist and doing the Bright program, they watch general survivorship cancer videos. So it's matched for everything except the content. Interim analysis of the ongoing pilot RCT showed that relative to active control, Bright results in a mean 31.8% decrease in body image disturbance at 1 month and 59.8% at 3 months. So even relative to an active control condition, appears to be highly efficacious. And exploratory quantitative mediation analyses suggest that Bright may improve head and neck cancer-related body image disturbance by improving body image coping behavior. Based on these, our clinical trial infrastructure and promising preliminary data, we propose that body image disturbance can be treated by a tele-CBT intervention targeting body image coping behavior. And the next logical step is to conduct a fully powered RCT to evaluate Bright's efficacy, examine mechanisms of change, and explore factors implementation, thereby establishing a novel treatment paradigm that directly addresses the lack of effective treatments for body image disturbance among head and neck cancer survivors. So the objectives of the R01 proposal would be to evaluate the efficacy of Bright, examine its underlying behavioral mechanism, and explore factors affecting its implementation. This is the proposed clinical trial schema. So based on our ongoing pilot data, we have a sample size estimate of 182 participants, which we recruited from 3 sites, MUSC, Henry Ford in Detroit, and WashU in St. Louis. So participants with clinically significant body image disturbance would be enrolled in the study and then randomized to either Bright or active control. And then we would measure outcomes at 1 week, 1 month, 3 months, and 6 months to examine the primary efficacy signal, mechanism of change. And then we would also conduct semi-structured interviews with head and neck cancer providers, psychologists, administrators, and patients at each of the sites to identify barriers to implementation, as well as conduct surveys with a nationally representative sample of head and neck cancer providers and psychologists through national committee work to identify potential implementation barriers at future collaborating sites. These are the specific aims for the R01. So aim 1 would be to evaluate the efficacy of Bright relative to active control on head and neck cancer-related body image disturbance and psychological and social well-being. Aim 2 proposes to examine Bright's behavioral mechanism of action, and aim 3, which is an exploratory aim, would explore the barriers and facilitators to the implementation of Bright in diverse clinical settings. So we would propose that this line of research in this R01 would help develop the first effective treatment to manage body image disturbance among head and neck cancer survivors, thereby addressing a significant unmet clinical need and developing new standards of clinical care, as well as elucidating the behavioral mechanism underlying improved outcomes for CBT-based paradigms for disfigured cancer survivors. So this is our fantastic research team, and I'm sorry I don't have the MRDA listed, but this was made possible by lots of grants from participating institutions and collaborators at MUSC and across the country. So with that, I will take questions, comments, feedback.